So the follow-up visit is extremely important after the initial therapeutic intervention. We try and get these patients back in about 2 to 4 weeks if possible.
Sometimes that's hard in our practice. You know, sometimes by the time they get their medication, by the time they deal with their getting it on board, kind of getting in a schedule, and we're very busy, so sometimes 4 weeks is a stretch, but if we can do it, I like it at that point as well.
Yeah.
No longer.
And here's where I think the visual analog scales really come into play, because now you've got your baseline set and you've intervened hopefully with, well, at least one intervention, maybe pharmacologic, maybe non-pharmacologic, or both.
Got to do both.
Or both. And you can look at the scale, so you want to make sure the patient goes through that whole scale again. Talk about compliance with sleep hygiene, which we discussed earlier, and their exercise routine. And again, here's an opportunity to modify their treatment plan with non-pharm and pharmacological interventions. Talk about their exercise, talk about how they're doing at nighttime and making sure that their bedroom is used primarily associated with sleep, and compliance with the medications.
It's a big visit because there are a lot of issues.
Yeah.
And sometimes I focus on mainly the medication piece of it, sometimes the exercise piece of it.
Yeah.
You know, it's really got a lot of facets to it.
We try and educate them about their disease all the time, and we'll give the Arthritis Foundation's fibromyalgia pamphlet to them. And I think that's the ACR also has a fibromyalgia sheet, which we hand them.
There's a good book called Fibromyalgia for Dummies that I encourage them to read, because it's got a lot of content in it.
I think the education piece is critically important for PAs and NPs, because without that, we're actually helping and assisting them to be more compliant with what we're doing.
Otherwise, it's too passive.
Yeah. So in the third section, we decided to place the patient on amitriptyline at 10 milligrams at night, in an attempt to try and improve the sleep architecture and the number of hours that they're actually sleeping restfully. We went over the sleep hygiene principles again to make sure that all the things that we had discussed previously had been done. We talked about the exercise program. In this particular case, what I will do is actually give them a prescription for exercise, and I'll write that out. 10 milligrams walking, flat level ground.
10 minutes walking?
10 minutes 3 times a week.
Yep. That's great.
So we've done the education, we've gone through the sleep, we've gone through the exercise, and the patient still comes in and says, you know what, I'm no better. I hurt all over. I'm not any better. And so what I try and do at that particular point is let those patient's symptoms actually drive the conversation and the treatment. So we'll change the dose of amitriptyline. I like to escalate that slowly, going along with the go low, go slow thought. And also to learn whether or not there's any acute exacerbation of the pain. Is there anything that could have made that pain worse over that interval period? Is there any emotional stress that's been added? Is there anything that's going on in their family that they may not be telling us? Or is there any physical activity that they've done, to see if we can kind of ferret out, you know, some of the reasons why the pain may be worse despite the medication. However, the medication may not be right. As you said, you use amitriptyline and cyclobenzaprine in kind of the more mild to moderate.
In the milder cases, yeah, I do, in the milder ones. And in the more severe, I really push more to the FDA-approved medications, because they really have the data behind them.
Yeah. So we're also going to make sure that the patient is being compliant. Are they taking the medication? Do we believe they're taking the medication? Are they actually taking the medication? That's always a conundrum. I think all of us feel like we're good enough practitioners to say, well, my patients take, you know, the medicine I prescribe them 100% of the time. But in fact, we know that's not true.
No, it can't be.
And then
we don't take our own medications 100% of the time.
And are there any side effects? Of course, we want to certainly bring those out, and those might be a reason. They may not want to disappoint you by saying, you know, I did have a side effect, or they may just keep it to themselves and say, I don't want to really disappoint, you know, my practitioner, because I want to get better and I want to make them feel good that I'm getting better. So you do want to go over the side effects, make sure that they aren't having any. Do you need to adjust the dose, as I said?
Well, I find the opposite is true with people with fibromyalgia. They often bail out of their therapies because of side effects. And sometimes I just have to hold their hand through it, like it's okay to have dry mouth. It's not the end of the world.
Right,
you know?
right.
And if you just kind of stick with your medications, oftentimes those side effects ameliorate.
Yes.
The body adapts to them.
I agree 100%, and I think it's, again, holding their hands, encouraging them, trying to get them to stay on the medication. So, again, we'll go over sleep hygiene, again, review those practices, and assess whether or not sleep apnea may be actually occurring. I think that's a big issue that primary care physicians and nurse practitioners and PAs need to know about. It's been stated that up to 80% of patients with fibromyalgia have some form of central sleep apnea. So I'm often ordering sleep tests, and I wonder if you feel the same way about that.
I think particularly in those that are obese. I mean, that it certainly sleep apnea is not restricted to the obese patient, but it's so common in them that to overlook that would be to overlook the obvious.
Right. The only other caveat I do use, if they have a significant other that can actually observe them sleeping, sometimes I'll say to the patient, is there somebody else that can watch you sleep for the first hour or so? And if there's any problems with snoring or periods where they don't breathe, I will use that sometimes. But oftentimes, I've been surprised by the sleep studies in patients who are not excessively overweight, who are mildly overweight and have sleep apnea. So that's an important point, and I think, again, restoring sleep is a critical component.
Totally.
Exercise, again, we try and use open-ended questions. How's the walking going? Are you doing it? That kind of thing. Or how's the swimming going, or whatever. We also want to give them expectations. I think that's very important as to what they can do and how well they should feel. I always say, look, if your pain level is on a 7 to 8, we're going to try and get it down to a 3 or a 4. That's not 0, and I think that expectation should be set up by the practitioner right from the beginning, that if we can effectively get you down from an 8 down to a 4, that's a significant improvement. It's 50%.
It's about management. It's not about cure. It's about making people more functional and making people less anxious about their lack of function. That really has a very dispiriting effect on folks. And so if they're experiencing a little bit more increase in function, I underscore it.
So then we come to analgesics, and we're going to talk about narcotics. I'm sure anybody in the audience has had this discussion with themselves, their supervisors, their colleagues, about whether or not opioid analgesics are used in fibromyalgia. One of the things that I always recommend when I talk publicly is to make sure you know your state laws, and certainly be in tune with your supervising physician or your colleague who you're working with as an NP as to whether or not narcotics are used. That opens up a whole different discussion. Analgesics have, in the opioid form and in the narcotic form that are controlled, have not usually been recommended by guidelines. There are some guidelines, the APS guidelines specifically, that will recommend them only if the other more benign treatments are not being effective. And that's a whole nother ballywick, and I think it's important to really talk about that for a second.
Because there are so many medical legal issues. I find the most confounding situation that of which the patient comes in to our practice on narcotics for fibromyalgia, and what are all the ethical issues that surround that.
Right. And one of the things that we don't do in the practice that I'm in and now in Danbury is we don't give them out to young people, and we almost never, and we very rarely give them out to older people. I think they're fraught with difficulties in the young and in the old. The old people could get disoriented, have a fall, that could be an issue. And younger people, I'm always worried. We tell them specifically, we're going to give you a small quantity. You have to make them last. That's not going to be something you get regularly. And we're very, very cautious.
Drug diversion is such a big problem. I mean, I practice in Florida, and we've had big issues with pill mills in Florida. It's on the front page all the time. At this point in time, narcotics really have to be used for malignant and non-malignant pain, in a very judicious way.
Yes, I agree with that. And I think
that doesn't mean you don't use them. It just
right.
means that you need to have the right drug at the right time for the right indication.
Right, and I think
there's not a lot of data that supports narcotic use in fibromyalgia.
Right.
That doesn't mean there isn't the occasional patient who has, bad osteoarthritis at the same time,
right.
that it won't help both situations. But
right.
I think that those are made judiciously and generally by somebody who's very comfortable and legally able to prescribe narcotics.
Yeah, and I would agree with that. In our particular practice in Danbury, we happen to have a pain specialist in the orthopedic section of Danbury Orthopedics. So that's a referral that I will make when push comes to shove. So one of the things following along that same line is whether or not you actually make that decision to prescribe an opioid. When it comes to that, we often use medication charts that have opioid sections in them. We can actually make a patient sign a contract to make sure that we're the only prescribers. Nobody else is using another physician or another practitioner to get that. And the whole process of actually screening for illicit drugs that patients may have taken prior to them coming to the office.
And it's very burdensome. And these are the areas that, pain-specific pain management centers are very good at.
So we've gone through the sleep, exercise, pain management, and so now we're going to develop a new treatment plan for this patient. We're going to try discontinuing the amitriptyline in this particular case and give them enalapril, which is a SNRI. It's serotonin and norepinephrine specific, and it is indicated for fibromyalgia pain. In Europe and in Japan, it's also indicated for depression and anxiety. We'll discuss how to start that. We start that one off at a very slow and low dose, and we build up as we've spoken about for the other medications. We'll reinforce the sleep hygiene components and recommend instead of walking, we'll try water if the patient is willing to do that. And so that's how we'll kind of go with the second visit, the follow-up visit, and hopefully that will make a difference in terms of letting the patient know we're committed to getting them better, knowing that they have different options other than what we initially prescribe, and that we have to deal with all the different issues in all of those planes as best we can.
And having the patient, really commit to being a partner in this. I mean, unless there's a buy-in from the patient, it isn't going to go very far.
Right. So the question comes up, Joan, is when to refer. And our audience is primary care practitioners. So the issues in regards to rheumatology, when to refer to rheumatology, is if you suspect whether or not there may actually be an inflammatory component to it. This would be increasing stiffness, for example, frank synovitis seen on examination.
Yeah, an absolute indication for referral is synovitis.
And so we look at rheumatology from the standpoint of if you should think that it's an inflammatory condition that's driving the symptoms of the patient and not in your league, that would be a good opportunity actually to refer to rheumatology. If the symptoms are very severe in terms of pain, and that symptom is the driving component, and there's some nuances to those kinds of symptoms that you don't feel comfortable with as a primary care practitioner, you would consider a pain medicine referral, provided you had that in your community, hopefully so.
Yeah, I mean, pain management centers, have systems in place for monitoring ongoing narcotic use, and that's becoming more and more important from a medical legal point of view.
Yeah. And lastly, and I find this not infrequently, if your simple measures for treating depression and anxiety, the ones we've spoken about, aren't working, then certainly a referral for psychiatry would be appropriate. And I find a good psychiatrist that is capable of working with fibromyalgia patients can be an extremely good value for those people who need that referral.
Yeah, that's one of depression and anxiety. Severe depression and anxiety have a lot of secondary fibromyalgia with it. So that is one of those comorbid conditions that we, really do not want to undertreat. And dense anxiety and dense depression, really would best be managed by a psychiatrist.
I think we both agree on all of those referrals.
Yeah.
So let's move on to the next section.